thank you all for coming. There'll be people coming in, some people going out. I think we have a little competition from down the street from Graham Cassidy, although perhaps that will dissipate as the day goes on. Thank you for being here. Just I want to make some introductory remarks and then introduce Eric Snyder from the Commonwealth Fund to welcome you, and then I'll go through what the panels will be doing today to try to encourage you to stay throughout the whole day. This all started, I don't know, 6-8 months ago when I guess Katie Merrill, who's one of our planning committee members, noted that, you know, it's the 25th anniversary of the Medicare Physician Fee Schedule. Maybe we should celebrate. That wasn't exactly the words. One thing led to another, and we decided to just sort of have an anniversary of the fee schedule. Wasn't going to accomplish very much for advancing a health care policy, but exploring the interactions of the Medicare fee schedule and the broad aspiration of moving towards value-based payment through alternative payment models was a topic worth exploring. And we got interest from the Commonwealth Fund to support this activity, and I want to introduce Eric Snyder to say a few words. Eric, by the way, is a senior vice president at Commonwealth. He's going to be on a panel later, so you'll hear a little more about him.
Yeah, thanks very much, Bob, and welcome everyone. Good morning. I'll be very brief. It's a delight to be here on behalf of the Commonwealth Fund supporting today's meeting, examining the history and future of the Medicare Physician Fee Schedule and its role in payment reforms. I realized this morning coming over here that I was a practicing primary care physician for about 25 years, and I realized I'd lived most of my life under the Physician Fee Schedule and had always thought that this was delivered on tablets to Moses at Mount Sinai. But now I understand, and of course as a researcher I understood that there was actually quite a detailed process for coming up with a physician fee schedule. So the fund, for those of you who don't know us, are going to celebrate our 100th anniversary next year. So we've been had the mission of advancing high-quality, affordable health care for everyone for quite a long time. The Medicare program is crucial to that mission, and enabling access to physician services was a cornerstone of the passage of Medicare, and that continues to be so today. I'll probably leave it at that, other than to say that the fund has, over the past 25 years, supported several investigators, probably many in this room, to better understand how to pay physicians and others in the healthcare delivery system, and to understand the impact of programs. I think one central question for us is whether this elegant solution, the physician fee schedule, is a bit like Alexander Graham Bell's telephone, an elegant solution for its time, which has then been superseded by advances that have now put smartphone computing platforms in all of our pockets. And so that's the image that I've been carrying in my head today. Is this a tool that can serve in future advanced payment models as we move forward in the future? But more to say about that. We're looking forward to learning about all of these topics throughout the day today. So thank you, Bob.
So I want to take us back briefly, and then panel one will do a little more of that, to where we were back in the late 80s when the work on the resource-based relative value scale that resulted as the basis for the Medicare fee schedule starting in 1992, the basis, what was the problem, what was the solution. A quote from the Physician Payment Review Commission, which was a predecessor commission to MedPAC and concentrating on physician payment. The more it learns, the stronger its conviction, this is PPRC, becomes that the pattern of relative payments based on screens for customary, prevailing, and reasonable charges has serious problems. Rationalizing the pattern of payment is a key part of reforming Medicare. And in fact, one could find other quotes that viewed the RBRVS reforms as part of the Medicare fee schedule as somewhat transformative. I still remember Bill Shao. Actually, we invited Bill Shao to come today, and he had a conflict, but regretted that he could not be here. But I remember him writing about how he used the case of an ulcer, which most physicians treat now with medication, and it's not as big a deal as it used to be. It used to be patients got sent for upper GI series, and it was a whole workup. That's before we realized it was an infectious disease. But his point was if we paid more appropriately within the fee schedule, more time with patients, less incentive to order tests, there wouldn't be a need for all that upper GI series, and people would have more time with their physicians. He was using that to sort of describe the potential of increasing value within the Medicare Physician Fee Schedule. Going back, I want to take a minute or two to read another quote because I think it is a lesson in humility for all of us as we look at value-based payment and what the potential is. Let me read this quote. In contrast to budget policy in recent years that concentrated on reducing price, expenditure targets would provide an opportunity for physicians to help achieve its cost containment objectives through actions to slow the increase in utilization of services. A collective incentive would be given to the medical community to reduce services of little or no benefit to patients. While not providing direct incentives to individual practitioners, such a policy would encourage the leadership of medicine to become more active in the support of activities to better inform physicians of the medical benefits and risks of procedures and to play a more active and constructive role in peer review activities. Expenditure targets would send a message that the need to slow the rate of increase in program and beneficiary outlays and provide physicians with constructive ways to respond. Well, in hindsight, that was wrong, right? We had the volume performance standard and ultimately the sustainable growth rate, and the sort of policy wisdom about that was that the collective incentive doesn't work very well. It's more like the tragedy of the commons when each individual tries to get a larger slice of the limited resource. So that was wrong, but it was well-intentioned, and I raised that as the context for when this fee schedule was being described and invented. It was actually called one of the payment reforms called prospective payment, along with DRGs, and ultimately the Balanced Budget Act of '97 had virtually converted all of the Medicare fee schedules into some form of prospective payment with the idea that it would be a more rational system for constraining spending, et cetera. So it is interesting now to see that the fee schedule is sort of a prototype of fee-for-service. Fee-for-service is volume-based. Volume-based has to be replaced, and we are moving down the road to alternative payment models. And yet, we still have the fee schedule. And in fact, most physicians in private and in government payment systems are being paid fee-for-service. So what we want to explore in detail is what are the interactions between the fee schedule and alternative payment models, and what is the role of reforming or improving the functioning of the fee schedule to better support the objectives of alternative payment models to increase value for beneficiaries and taxpayers. So we have 4 panels that will explore this in some detail. Panel 1 will explore in more detail the original intent and how it has evolved over the 25 years. We'll talk about current reform ideas that have not yet been implemented as well as those that have. Panel 2 will be a physician panel, physicians who have been actively involved with alternative payment models, whether it's bundled episodes or capitation, other forms of shared savings and ACOs, but also are very knowledgeable about the Medicare Physician Fee Schedule to comment on those interactions and how to provide greater complementarity or synergy between the two approaches. The third panel will be more technical in nature. It will explore some of the alternative bases for establishing relative values. We moved from charge limits to resource-based back in 1992. There's some other countries that look at trying to achieve target incomes for different specialties. There are approaches to use behavioral responses to fee changes. We have some experience with that actually in the US, but in Japan, they have reduced the price of MRIs consecutively until they see a behavioral response that might suggest access problems. So they are using sort of market factors to adjust fees. And then there's the possibility of using policy objectives to alter fees. In the U.S., CMS does not have the authority to do that. Congress has to do that, so Congress can, for a period of time, provide a 10% increase, for example, for primary care physicians' E&M services. But CMS is within the constraints of the statute, has to sort of assess resource costs. We will explore those details and other technical aspects of the fee schedule. And then finally, we will have a policy panel on the issue of, is it worth it? If there's a broad consensus that fee-for-service is volume-based and really a remnant of a previous time, and should we be expending the opportunity costs to even improve the fee schedule rather than moving more assertively to alternative payment models? And we will have a policy discussion about the role of fee schedule improvement in a world of alternative payment models. We will also have a luncheon presentation. The program was a little vague about what that was all about. It's because we had a speaker scheduled to come from Berlin, who's an expert on European healthcare systems, and a week ago he informed me that he had been on the queue for an adoption, and it came through last week, a 10-day-old baby. So he is very happy. We are very happy for him, but he could not come. So we quickly pulled together 3 other experts on Canada, France, and the UK to give a flavor for how other countries are viewing payment to physicians, the role of their established payment model, and the goals of increasing value. And so that's what the luncheon session will be about. And so with that, I want to stop and, hello, Grace, and turn it over to panel 1. We're a little bit behind schedule, but not much. So I hope you can stick with us all day. If not, we will be streaming, et cetera. There'll be others coming in. It will be I think, a substance-filled day, and thank you for coming. So with that, it's time for panel 1. Lauren, it's yours. Thank you.